Yep, I am
This
ready.
meeting is being recorded.
Fantastic. All right. Hello and welcome everyone to our Greater Atlanta chapter meeting for August. We hope that you had an amazing have had amazing summer months. The COVID has ramped up a little bit and now we're dealing with a little thing called monkeypox. So hopefully you all are preserving your sanity as we go through this time. So I'm going to get started with a few announcements. I just want to put a plug in there for the GIPN conference that's happening next month, September 28th through September 30th. There will also be some pre-conference educational opportunities. There'll be an intro to IP session and a CIC certification course as well. And I'll be sure to post the link to the GIPN conference registration in the chat. Also, you guys save the date for Friday, December 9th. 2022, we'll be meeting together again for our chapter holiday luncheon. This year we will be at Zoo Atlanta. So that's so exciting, so happy to be back together once again. We will have a guest speaker from the CDC. So you guys save the date again for December the 9th, 2022, and more information to come regarding that. Now I'm going to turn it over to Pam Polk to give us a bit more information about some scholarship winners that we recently had.
Thanks, guys. Hey, this is really a wonderful opportunity. APIC we're working with Project First Line through the CDC, and we were able to provide scholarships to 4 people to go to the CIC scholarship, the CIC program for continuing education to get ready for the CIC test. So I'm going to announce the winners. They already know who they are, but these are the people that won the CIC scholarship to GIPM. Sade Adelamo from Lawrenceville at Northside, and Allison Weichert from Northside Gwinnett, Jessica Saddlemeyer from Northside Atlanta, and Joy Williams from Piedmont. So congratulations to our 4 winners, and they got the scholarship money to go to the course at GIPN. So congratulations, y'all.
Yes, congratulations to these 4. And then I also wanted to add that we had 6 more applicants, and we have in all 10 individuals interested from Region D who will be going to the CIC prep course. And Pam, I wanted to thank you for bringing this to our notice and helping us get these scholarships out.
Yeah, great, everybody. I'm glad 10 people get to go. That's great. Thanks, Tanu.
Awesome. And again, thank you, Pam, and congratulations to our winners. I'll now turn it over to Beth Morrow, who is the chair for our nominating committee.
Thank you, and thank you all for supporting GIPN as well. I'll be presenting at both the Introduction to IP as well as the CIC review, so I'll look forward to having all of those scholarship recipients in my classes. I did want to remind everyone that it's that time of year again for elections. We have 2 board elected positions open for 2023 year. Cannot believe I'm saying 2023, but both the president-elect and the secretary positions will both be available for 2023. So be watching your emails or watching the website. We'll also have information in the upcoming newsletter about willingness to serve. If you are willing to serve, or if you just have questions or concerns about how the board works or how you get involved, please feel free to reach out to me. I included the email in the chat, but it's nominating@apicatlanta.org. So please feel free to reach out if you're interested. We are would love to have a really robust ballot to be able to choose from, and find out if anyone's interested in even committee work with the board or anything like that. I'm happy to support that. Thank you, everyone. Great to see people.
Yes, thank you, Beth. And again, just reiterating, it's really awesome to get involved with your local chapter. There's so many opportunities available, so definitely consider joining one of our committees or running for one of these upcoming positions. All right. So now we'll move on to Caleb Price, our membership chair.
Hi, everybody. I just wanted to give an update on kind of the emails that you get from APIC, from our chapter. If you are not getting emails from our chapter, please check your spam folder, or if somebody else on your team says they're not getting the emails. Generally, that's where they're going, especially if you use your work email. Your institutional IT policy might be set up so that anything that comes from a mass mailing or through MailChimp, which is what we use to organize our email list, they may flag that as advertising, and so then they'll put it into your spam folder. So far this year, I think everybody that's had an issue with not receiving our emails, they've been going to their spam folder. So just check that. But if that's not the issue, feel free to email me at membership@apicatlanta.org, and I can look in and see what the issue is and make sure you're on our list properly.
All right, thank you so much, Caleb. I will now turn it over to Mary Pearson to introduce our speaker.
All right, good afternoon, everybody. So I'm going to introduce our speaker that we have today. Dr. Terri Rebmann is a special assistant to the president, director of the Institute for Biosecurity, and a professor of epidemiology in the St. Louis University College for Public Health and Social Justice. She is a PhD nurse researcher with an emphasis in infectious disease emergency preparedness. In addition, she is board certified in infection prevention and epidemiology and a fellow of the Association for Professionals in Infection Control and Epidemiology. She publishes and lectures on bioterrorism, pandemic planning, emerging infectious diseases, and infection prevention practices on a national basis. Dr. Rebmann has served on several national and international task forces and committees aimed at minimizing morbidity and mortality related to emerging infectious diseases and bioterrorism threats. Examples include being a member of the APIC COVID-19 Task Force, a member of the APIC Ebola Task Force, and being a former member of the chair of the APIC Emergency Preparedness Committee. She is also a current board member of the Certification Board of Infection Control and Epidemiology. So now I will turn it over to our speaker. If you want to go ahead and share your screen, and then you can advance your slides.
Thank you. And thank you all for having me here today. I'm very excited about this topic in particular. So today I've been asked to talk about infection preventionist experiences during the COVID-19 pandemic, specifically findings from two sets of focus groups that the APIC COVID-19 Task Force conducted with APIC members. So the objectives for my presentation this morning, I'm going to describe reasons why the focus groups were conducted with APIC members, outline the findings from those two focus groups that were conducted. The first set were conducted in fall of 2020 and the second set in fall of 2021. And then also briefly talk about what we have done with those focus group findings, how they have helped to inform practice, and some publications that have come out in relation to those findings. First, I wanted to say I am just one member of the APIC COVID-19 Task Force, and two of the other members are actually members in your chapter. So Jill and Pam, thank you for all your hard work on the task force for these last couple of years. Of course, this is a group process, so I am just representing the work of this entire wonderful group of individuals. Okay, so some background before I talk about the focus groups themselves. If we think back to what was happening in spring of 2020, we saw those very first cases of COVID-19 in the United States, and what we were seeing was a surge in healthcare. What we were hearing is that there was anecdotal information that personal protective equipment was starting to be lacking across healthcare systems and in healthcare facilities, but we didn't have any hard data about exactly what that lack looked like. So exactly how much PPE was available and what hospitals and healthcare systems were doing due to that lack of personal protective equipment. So at that time, the APIC COVID-19 task force was put together by APIC at the national level, and our task force conducted a member survey to ask and try to get a gauge on what was happening with PPE at the national level. And so what happened, many of you will remember, we conducted the survey, we released that data, and it showed that essentially many healthcare systems and hospitals were running low or even out of important pieces of PPE, including many were running low on respirators and masks, face shields, goggles, etc. This made the national news, and it actually prompted the government within about 24 hours. The government then activated the Defense Production Act, which enabled industry to start focusing on producing more PPE for healthcare. So that survey was very instrumental in helping to sort of make that change in practice and provide more PPE for healthcare nationally. So then fast forward from there. So that was the spring of 2020. And then in fall of 2020, of course, we were still dealing with the pandemic. And we were starting to hear some new anecdotal information from individuals, from our colleagues and from our friends. And what we were hearing is that PPE access was getting better, that people felt more comfortable. They felt as though they had more PPE in general. But we were hearing that infection preventionists were really struggling due to a very high workload for such a long period of time, and that they were struggling due to the conflicting guidance that was available at that time. So anecdotally, we were hearing that, local public health officials' guidance was not the same as state guidance, was not the same as CDC guidance. And so there were just these conflicts that were creating difficulty for infection preventionists. But this was all anecdotal information that we would just hear again from friends and colleagues. There was nothing that was actually quantified. So in what we did in response as the APIC COVID-19 task force is we conducted 2 assessments in the fall of 2020. We did a follow-up PPE survey, and then we also conducted our first set of focus groups. So the question some people have asked is, why the focus group? So we did that survey on PPE, and what we found is that in general, people did respond that they had more access to PPE, but primarily that's because individuals or hospitals and healthcare systems had implemented crisis protocols. So that enabled them to have access to more PPE, but it wasn't the way that we would use PPE during non-pandemic times. So that quantitative data that we got from those 2 surveys is great. And in general, quantitative data is wonderful. If you have data points that are easily measured, if there's something where you can ask, for instance, what percentage of infection preventionists or what percentage of hospitals currently lack access to adequate PPE? That's a great question to put on a survey. People can say yes or no, or we have a lot, or we don't have much. You can study those things quantitatively. Qualitative data in general is better when you are looking at more nuanced information or nuanced data. So for instance, if you want to know what kind of impact the pandemic is having on infection preventionists on a personal level or a professional level, it's really difficult to measure that quantitatively. So you need those qualitative open-ended questions to really get at some of that more nuanced information. Qualitative data is also better, or a qualitative research approach is also better if you don't know exactly what you want to measure. So for instance, if you want to know exactly what infection preventionists are facing in terms of current challenges, you have to ask that in an open-ended way, in a qualitative way, because you don't know how to ask about lack of access to adequate PPE. You don't know what the challenges are to try to even measure the exact impact from those challenges. So that's why we chose focus groups in addition to that survey that we conducted, because we really wanted to get our hands around what was happening, what were the major challenges that were happening at that time in the pandemic. So in fall of 2020, we conducted 7 focus groups over the course of September and October. In total, we had 73 infection preventionists that participated. That's on average about 10 IPs per session. And the way that this broke down is that, generally speaking, whenever you have focus groups, you try to have a pretty good group where they're all very similar in terms of either their knowledge or experience or their work setting, so that they feel comfortable talking to each other about what challenges they're facing, and also so that you don't get individuals giving you wildly different kinds of answers. Because generally speaking, if you talk to everyone in acute care, they might be having the same kinds of challenges versus talking to individuals that work in an outpatient setting where they might have you would anticipate a different set of challenges. So the way that we set out the focus groups, the 6 focus groups originally, acute care, outpatient, long-term care, rural, those IPs that work in rural settings, one focus group for new infection preventionists, and then one focus group with experienced infection preventionists that had more than 10 years of experience. So that we started out with the 6, but what happened was early on, we did the focus group with the rural IPs. And what we found is that focus group was so different than anything else we were hearing in the other focus groups. We heard a lot of emotion, we heard a lot of very difficult challenges, and we felt like we needed more information from that group. Like that single focus group didn't feel like enough data to really analyze the challenges that they were facing. So we actually added a second session just for rural IPs. So that's how we ended up with the 7 focus groups. Again, because the data was telling us that that group of individuals or that setting was just so different than what we were seeing in other healthcare settings. So the results from the 2020 focus groups, we summarized those. We sent a report to APIC National, to headquarters, with the general findings and some recommendations about what we thought should change. But we also published 2 papers. Both of those were published in APIC. One was sort of a general findings from all of the focus groups, and then one paper was specific to those rural IPs and the rural setting. So now I'm going to talk about these 2 papers specifically, and I'm going to start with the general findings paper. And I have this on the screen, and I'm happy to send you a PDF of these 2 articles if you would like to read them in more detail. So the first major finding that we had was the good news is that infection preventionists were reporting that they felt like there was new recognition and respect for infection prevention as a profession, that people finally kind of knew who IPs were, or at least had heard of infection prevention, and they felt as though there was just more respect for what we were doing as professionals. And so that was very gratifying for the IPs. That's what we were hearing from them. And this was reported more in the IPs that work in long-term care settings. They felt as though in long-term care, infection prevention had always been a little neglected, a lack of respect, not a lot of dedicated time. And so this new recognition and the realization that we need dedicated, trained IPs in long-term care, they felt was like, if there's any kind of silver lining from this pandemic, they felt like that is the one silver lining that they were seeing. Some bad news that we found, most IPs that participated in the early focus groups in fall of 2020 said they did not have a seat at the table in terms of pandemic response. So they were not included in developing the crisis protocols, the COVID protocols. And what this meant is that they ended up feeling as though the protocols were not evidence-based. They didn't feel comfortable with the safety of some of the protocols that they were putting into place, and they were unable to sometimes answer questions of their staff about the protocols because they weren't involved in those discussions. So what I did, whenever you do qualitative research, it's very helpful to include actual quotes from the focus group participants. So throughout this presentation, you'll see I have boxes. They're either blue or that orange color from the APIC slide. And those, anything that's in one of those blue boxes or an orange box is an actual quote from a participant that gives you a little bit more context about what this is what they actually said during the focus group that led us to these conclusions. So for instance, this person said, decisions were being made in organizations without IPs, which was resulting in extreme difficulties in coordinating throughout their county. So other findings from the early set of focus groups, they did report on continuing to see PPE and infection prevention supply challenges. Even though we had that initial survey, and even though the Defense Production Act had been implemented, there were groups that were still seeing a lack of PPE and a lack of infection prevention supplies, including like hand hygiene products, disinfection products, and other kinds of infection prevention supplies. So for instance, many reported that they only received a fraction of what they would order a large amount of PPE, and then they would only receive a fraction of that back from their vendor. Some reported they were seeing PPE theft, and so they needed to lock up their PPE and have better controls over it so that it didn't disappear. There was a lot of confusion reported about the PPE protocols, especially because as I'm sure all of you remember, and it's still happening, the science is changing so quickly that this was causing rapid changes to PPE protocols. It was resulting in a lot of confusion among the staff about what the current protocols were and if they were actually evidence-based and exactly what the science said. In fact, in the focus groups, 89% of those, we did ask a few quantitative questions of the participants, and 89% of the IPs said that they had implemented the crisis standards of care related to PPE. So almost all of the IPs were using crisis protocols for PPE and still having some challenges with that. And so I put a couple of what I think are really good quotes on the slide. So for instance, at one point, one of the IPs said at one point we had to use pool shock, which their pharmacist diluted into bleach to make a bleach spray. They said about the theft, staff had to sign out which PPE they took for the day and then check to make sure that the counts were right to make sure that PPE wasn't disappearing essentially. And they were also reporting that social media was contributing in a negative way and really amplifying some of these challenges related to PPE and also related to the rapidly changing science. So for instance, social media was reporting that PPE was being reused in urban areas, but in the rural areas, at least early on, they were not reusing, they weren't using the crisis protocols. So that was creating a lot of confusion and anger among some of the staff. And one quote I thought was really great from one of the IPs said, the frontline staff, they just didn't trust what we were telling them, nor what CDC was telling them about how to reuse and decontaminate respirators safely. We also heard very loudly from the infection preventionists that one of their major challenges was that there was a lack of setting specific guidance. And so they, I shouldn't say loudly, they weren't talking loudly, yelling loudly during the focus groups, but we heard consistently would be a better way to say this. We heard consistently that the IPs that covered the non-acute care settings, so outpatient clinics, hematology clinics, and home health in particular, that because the CDC and public health departments weren't releasing those setting specific guidelines, they just didn't know how to respond the best way. So for instance, one of the IPs had said, and I believe this was somebody working in home health, I feel like I'm kind of making it up as I go. You're really coming up with answers right there on the spot because nobody has the answers because the guidelines just did not exist. And so this left the IPs feeling unsure about how they were supposed to train their staff, how they should answer questions, or even how to develop their evidence-based policies. We also heard, and again, this is a reminder, this was fall of 2020. So this was now almost 2 years ago. They were already reporting that healthcare personnel were reporting and they were seeing pandemic fatigue among those professionals. There was PPE fatigue. The healthcare personnel were tired of wearing the respirators and the eye protection, gowns and gloves all the time. And mask fatigue specifically, mask and respirator fatigue specifically is what they were hearing from their staff. And so they were also reporting that the healthcare personnel, they were willing to wear their PPE at work, but there was less willingness then to wear it in social settings. So for instance, one IP said, our staff say we don't want to wear PPE when we're not at work. We don't want to have to change our personal life. It's bad enough to change it at work, but to change it at home, it sucks. And then IPs also talked about how staff started to let their guard down. The PPE fatigue was leading them to make errors in infection prevention practice. So they let their guard down in the break room. And so this particular IP said they had a case of 7 ER residents who all went to a brewery together, and then the disease got transmitted. And they were like, oh, that's because I only need to wear my PPE at work. So the PPE fatigue really seemed to have an impact at work and in individuals' personal lives as well. In the IPs that work for long-term care, we heard different challenges from them, or sometimes maybe more amplified challenges among the long-term care IPs. They reported that they were less likely to have access to PPE compared to IPs that work in acute care settings. They also reported that because their vendors weren't able to give them the normal amount of PPE, that they were finding new vendors. And that sometimes meant much higher prices in terms of ordering PPE. So as one IP said, I think I spent $46,000 yesterday on PPE, but I had to. We finally found supplies and you just can't wait. The IPs in long-term care also talked about the challenges related to testing requirements that were and still are specific to long-term care settings. So I know that regardless of where you work as an infection preventionist, you probably dealt with some level of testing requirement challenges. But in long-term care, the protocols were changing very, very rapidly. They were much more extensive. They were very difficult to implement. And there were a lot of questions about rapid tests versus PCR tests and when to do which one and how to interpret findings. And keep in mind, again, this was 2020, so we knew far less back then about how to interpret these tests and what those test results meant. And there was also less access to testing supplies in general compared to where we're at today. So the IPs in long-term care were talking about the challenges they had, and one of them had said, we have to test all of our staff depending on county incidence rates. So there were times when they were just doing mass testing of all of their staff and sometimes all of their residents as well. They talked about the challenges related to the lack of guidance around testing, as I just mentioned, and they were seeing a lot of low staff morale in their staff during the pandemic. So as one IP said very eloquently and also to me very sadly, you know, in the hospitals, they've been able to focus on the COVID survivors. How many people have been cared for and how many were able to leave healthy. And many of you might have even seen some of those videos, or maybe you even did those at your own hospital where they would cheer for the survivors as they were able to leave the hospital. But as this IP said, like they can't have that kind of a focus in the nursing homes because even if they survive, they still stay in long-term care. So it was just a different kind of atmosphere, and it led to more low staff morale for those long-term care IPs. So that was essentially the findings from that first paper. Now I'm going to specifically talk about the findings from the two focus groups with the rural IPs. So this could be individuals that work for one of those critical access hospitals, or it could just be any other rural setting. So the IPs were able to self-identified as working in a rural setting. So on the left-hand side, you see a picture of the article that was published in APIC that summarizes these findings. Again, I'm happy to send a PDF of that article to anyone who wants to read this in more detail. So with the rural IPs, we're reporting that compared to IPs that worked in suburban and urban areas, they were less able to get access to PPE. In general, the PPE was prioritized for larger hospitals and systems. The vendors liked having those bigger orders. It was more of a priority. And so the rural areas just were less able to get that PPE. Some reported they had resorted to using garbage bags for isolation gowns. There are pictures of this on the internet. I know this made the news as well. This picture is not from the focus group participants, by the way. This is just a picture that was sent to me about some of the healthcare personnel that were forced to wear garbage bags instead of isolation gowns. And so as one IP had said it, they've had this challenge as a critical access or small hospital, that they're the little guys and they didn't have as much pull with the vendors and getting PPE because the vendors basically wanted to go after the bigger hospitals and bigger orders. The rural IPs also talked a lot more about, there was a large focus in those focus groups and a lot of conversation around the misinformation and disbelief about the pandemic that they were hearing among their community members, a little bit with their healthcare personnel, but more so with their community members who would come to the hospital or their healthcare setting. They talked a lot about the politicization of the pandemic and how politics was helping to feed into some of this misinformation and disbelief that the pandemic was even occurring or that this disease was truly serious. And so they had just a lot of really good quotes about the impact that this had on their healthcare setting. So for instance, one IP said they have a lot of fights at their screening table. People don't believe the pandemic is real. Someone else had said that they live in ranch county or country. They have a lot of non-believers. and that they believe that this is just a conspiracy of the government and people in their community don't want to wear masks and they didn't want to do physical distancing. And one IP talked about how they had a security guard that was attacked by a visitor who was upset about the mask mandate, and that visitor just wanted to get into the emergency department to see a family member, but did not want to have to wear a mask. So they had a lot of really good and emotional quotes about the impact that this was having on them that we didn't hear as much in the IPs that were in acute care settings that were in suburban and urban areas. We also heard something unique among the rural IPs, that they had more of a sense of obligation to their community. The way that they described this was because they live in a smaller area, small towns, they felt like their community members knew who they were. And so as one IP said, your job becomes your personal life. Those lines get really blurred. And so they felt this extra sense of obligation. And in some cases, the IPs said that then they felt like there was this obligation not only to respond to the pandemic, but they were afraid of becoming infected, not only because they were afraid of the health impact it would have on themselves or their family members, but as an infection preventionist, they felt as if they got infected, that was sending the wrong message to the community, that they had done something wrong, that they weren't following the science, or that they were making mistakes somewhere along the line in infection prevention. So they had this different sense of obligation to their community than what we heard from other infection preventionists. But on the positive side, so the positive side of living in one of these smaller communities, the IP said is they had this sense of reciprocity from their community. So on one hand, they felt the sense of obligation to their community, but on the other hand, they felt as though their community was more willing to give back and support them because they all know each other, because it's a more close-knit kind of community. So for instance, the rural IPs talked about churches making homemade masks and other PPE, a plastics company that made face shields and isolation gowns. And there were numerous stories like this from the infection preventionists about this reciprocity that they were getting from their community members. And then sort of fast forward to what happened in 2021. So those were the focus groups in fall of 2020. And then in 2021, there were major changes in terms of the pandemic, of course. We finally had access to the COVID-19 vaccines, but we also had the Delta variant that emerged in spring of 2021. So because these things changed and had a huge impact on the pandemic, when the APIC COVID-19 task force, we were continuing to meet throughout all this time, of course. So in fall of 2021, we started having conversations about, like, where is the field right now? What's happening with infection prevention? What are the challenges? What impact did the Delta variant have? We kind of thought that the pandemic was either ending or getting a lot better because we had the vaccine. There was this great sense of hope once the vaccine first became available. And then the Delta variant came, it was more severe. There were breakthrough cases. And so we had this anecdotal information that things had changed, but we really didn't have a great idea about exactly what had changed or what kind of impact that was having on infection preventionists and infection prevention as a field. So in November and December of 2021, we conducted a second group of focus groups. So we conducted 6 new focus groups in 2021. Just a note to kind of remind you, because I know that the timeline for some things that happened in the pandemic get a little blurry, but this was happening at the end of the Delta waves, at the start of the Omicron wave. So the very last focus group that we conducted was right around the time that the very first Omicron cases were identified in the United States. So the early focus groups, we were still basically all Delta. And then by the time we were ending the focus groups just 1 month later, we weren't talking about Delta anymore and everybody was talking about Omicron. But the focus of the focus groups was about the impacts from the Delta variant. So there wasn't much conversation about Omicron at that time. So the 6 focus groups, we did 2 focus groups with system level infection prevention directors. We did 1 with long-term care, 1 with acute care, 1 with rural IPs, and one that was a combination of IPs that work in behavioral health, home health, hospice, and ambulatory care. So the goals of the focus group were to assess the impact from the Delta variant, the impact from the COVID-19 vaccine, how the IP role had changed over the last year and a half-ish of the pandemic, and also asking questions about the IPC landscape as a whole. What was hiring and retention of IPs looking like? Because anecdotally, we had heard that there were a lot of changes, a lot of people leaving the field, a lot of people leaving early, difficult to hire IPs. And so we wanted to collect some more information about that particular situation. Now, this is unpublished data. So we are still in the process of writing this up. We've moved, Omicron hit much harder than I was anticipating. So it's just taken us, unfortunately, a lot longer to write this up than it did the first set of focus groups. So I apologize. So the data that I have, I'm not sure exactly what's going to end up in the paper or papers. So actually what you're hearing, you might not actually ever see in any kind of formal writing, but we'll still go ahead and talk about it because I think the data is very important. And we did send a report to APIC National. So they have this data. They are aware of the findings from last fall, even though we haven't officially published the data. So the good news is that what we heard last fall is that infection preventionists were saying they are more involved with developing pandemic policies than they had been the previous year. So I think that's incredible. Partly that was because when we had those findings from the first set of focus groups, APIC headquarters got involved and started advocating for the need to have IPs more involved in pandemic response and developing these policies, or at least in vetting those policies before they were released. So we did take those findings from the first focus groups and actually make practice changes. And so last fall, what we were hearing was that this was actually very successful. So as IP said, they had a seat at the table. One talked about their role had actually expanded and beyond what they were originally doing in infection prevention and had moved into the communication realm. And then other IPs had said, like one had said, we're very involved in all the things. They were in the incident command centers. They helped with contact tracing, calling patients, making policies and procedures. So this was a really positive change for the field in just a single year, that IPs were finally getting a seat at the table. We also heard not just from the IPs in long-term care, but IPs in general, that their expertise was even more recognized and respected. And this also meant that what they were seeing is now the field, the healthcare field as a whole, was recognizing there's an increased need for infection preventionists, more need for them in long-term care, more need for them in other areas, including things like the Carnival Cruise Lines and Doctors Without Borders and other organizations that might not have seen that need for infection prevention expertise before. And now they recognize how important we are and the contributions that we make. And so there was this real sense of pride in the infection preventionists last fall about that now IP is really getting the recognition that we have deserved for a very long time. And as one system director had said, the administration recognized how important IPs are, and they were actually able to create more positions for their healthcare system. So that's an incredible, wonderful silver lining, if there is one, again, from the pandemic. So as I briefly mentioned before, so now that what the IPs were reporting is there was this new increased need for infection preventionists and IPC staff in general. And they were also seeing really high IP staff turnover. So what they were hearing is that there were IPs that were retiring early because they were exhausted, they were burned out, and they just didn't want to continue. If the pandemic wasn't going on, they might have stayed in the role, but this sort of made them decide to go ahead and retire early. There were also IPs that talked about new IPs coming into the field and then quickly leaving because the pandemic, the work was just so overwhelming to them that they just didn't want to stay in this field. So for instance, one had said a new IP, literally within 2 months, she was gone. She ran out the door. She wanted nothing to do with the pandemic. And I find this really sad because, of course, I love infection prevention and I mentor a lot of new IPs in the MPH program that I helped to manage. And so I find this really sad that, you know, someone new into the field, usually they're so excited and they really love the field and they stay long term. And so to have somebody come in and within just a short amount of time just feel so overwhelmed because of the pandemic work to leave, I find that really sad. Another IP had said they were seeing a 50% turnover of IPs in one region. Out of a team of 16, 8 IPs had left their position within a period of 9 months. So this, of course, creates a lot of gaps and needs in infection prevention. And it means that it's harder for the IPs that are still working to do their jobs because many of them are doing the job of more than one person. So there were just a lot of challenges reported last fall in terms of infection prevention as a field. The system directors and those who hire infection preventionists also told us that they had all these open positions. It was just really difficult for them to find qualified IP staff. So there's some great quotes here. Somebody had said there's just really no one who will even apply for infection prevention. Someone else said it's just difficult to recruit infection preventionists. Another had talked about how it's hard to find experienced IPs. So they were taking on a lot of newer IPs, which is great because we do need to build up the field. But then it makes their current IP staff really tired. They're already tired from the pandemic, and they just don't have the energy to train the new IPs. So there are all these challenges of finding new qualified IPs, retaining the IPs that were already on staff. I'm sure many of you have probably experienced similar things. One change that was reported in IPC as a whole across the nation, at least in our participants, is that the individuals that are hiring IPs found that they were really having a hard time hiring the traditional routes into infection prevention, microbiologists and nursing, the two main routes in the past into infection prevention. And instead, they were moving more towards increased hiring of MPH graduates as infection preventionists. They were recognizing that, one, MPH graduates do have the skills needed to work in infection prevention, but also that there were more MPH graduates coming on board or coming out of these programs. There was this need for infection prevention, and so some of them were starting to change their hiring practices. I know for a while in IPC, my experience has been as a mentor to some of these MPH students is that some, when they graduate and they want to move into infection prevention, there are some hospitals or healthcare systems that will not hire you unless you're a nurse. And many of our MPH grads are not nurses. And so some of them were having a difficult time finding jobs in infection prevention. So instead, over the course of the pandemic, what I've been hearing, and it's confirmed by these focus groups, is that more hospitals and healthcare systems were open to the idea of hiring these MPH grads and moving them into infection prevention. And I think this is wonderful for the field. I have found that the MPH graduates are very successful in the infection prevention field. So one of our major questions that we asked about were the challenges and the benefits of having the impacts related to having the COVID-19 vaccines available. And so what we heard was that the vaccine provided this long needed hope. So infection preventionists were feeling almost hopeless after the first, year of the pandemic or so before the vaccine was available. Then it was like, okay, we've got this new vaccine, and there was this hope that the pandemic was going to end or things were going to get so much better. They did talk about how once the vaccine became available and healthcare staff became vaccinated, what they were seeing was PPE compliance started to drop, that the healthcare personnel were saying I guess they felt maybe, no longer susceptible to COVID-19. And so their PPE compliance just went down. They felt like they didn't need to wear the PPE. They were vaccinated, they were protected. There were a lot of misperceptions reported about the vaccine that they were hearing among their patients and among their healthcare personnel. And many were reporting that the vaccine had become this really politically charged issue. Of course, we all know that this has been a very politicized issue, but the infection preventionists really spent a great deal of time talking about the impact of politics related to the COVID-19 vaccine. And they were also saying, again, this was fall of 2021, that they were starting to feel hopeless in the pandemic, that, as one IP said, the hope they had related to the vaccine was lost when the Delta variant hit, because of course there were breakthrough cases. Delta caused more serious disease, so they were seeing more sick patients, more severe cases, more people dying from COVID-19, and it was just causing this sense of hopelessness in their healthcare staff and also in the infection preventionists. So as another IP said, the day the vaccine came out, first time I'd seen hope among our team members, and you kind of lived on that hope for a bit. Didn't take long for that hope to turn to despair, because they were in a rural area and they had one of the lowest vaccination coverage rates in the country. We also heard that the infection preventionists were saying they felt that there was this increased responsibility for IPs, but they didn't have the authority to really implement some of these new policies. And so it was just this, it could be a very frustrating situation for some of them. The system directors in particular talked about how there was a lack of investment in IPC infrastructure. So yes, there was this recognition that infection prevention is very important and it's necessary, but they just weren't given the financial support that they needed to build that IPC infrastructure to have a really successful infection prevention program. And that was leading to a lot of frustration among the system directors. Many reported that they were receiving poor quality personal protective equipment and that they were spending a lot of time needing to vet that PPE for quality, that they it just didn't feel like it was safe to use some of that PPE. And here was one of the best quotes related to that. Multiple times we'd have to bring in new types of gloves. We would just get complaint after complaint that the gloves would break, gowns would tear, or you couldn't wear them for a few minutes without being drenched in sweat, but they didn't have any alternative. So the quality of the substitutions was not great. They had dollar store raincoats as isolation gowns for about a month. So there were a lot of challenges related to PPE continuing in the second year of the pandemic. And then there were a lot of reports that the staff had resorted back to presenteeism, and that is when healthcare personnel, or really anyone, reports to work when they are sick. There wasn't a lot of time spent on this, but there were a large number of infection preventionists that mentioned that they were seeing sick employees report to work, even though they knew that they were not supposed to come to work when they were sick. So that was one of the negatives that they were reporting. And then in terms of burnout, so there was a lot of conversation about burnout among the healthcare workers, and also about burnout among the infection preventionists. So a lot of really, really great quotes related to what they were seeing in their colleagues and also among themselves. As one said, the burnout is tremendous, and it's not just a little bit, pretty much all the staff in the hospital are burned out. Another talked about, actually multiple IPs talked about moving from traditional healthcare personnel to more contract staff because they just couldn't hire sufficient healthcare personnel full-time. And that was really a morale buster because the contract staff were paid so much more, like using traveling nurses, for instance, so much more than the regular staff. And so it was creating a lot of tensions in the healthcare workers, a lot of burnout, a lot of anger, a lot of frustration that the contract staff were paid so much more, didn't understand the protocols as well, and they didn't feel like they were as invested in working for that particular institution as the regular staff. So just a lot of frustration around that. They also talked about how the pandemic fatigue had really changed. So the first year pandemic fatigue was more about not wanting to wear a PPE because you were exhausted and tired of wearing a mask or a respirator and putting it on and taking it off and that kind of thing. But now the pandemic fatigue had really changed to derision. And there were IPs that talked about patients actually heckling the healthcare personnel. And as one healthcare worker, or as one infection preventionist said, it's like we went from healthcare hero to the worst person in the world. And it was just heartbreaking to hear the IPs talk about this. After that first year of the pandemic, there were so many stories about healthcare heroes, and there were signs, and people would bring in food, and I know everybody was exhausted, but there seemed like there was a lot of community support. And then last fall, that changed, and that same support didn't seem to be there, or at least not consistently. There were a lot of IPs talking about how that had changed. And with that change came this burnout and this unhappiness and just a lot of difficulties with IPs continuing to manage. So not only were the healthcare workers burned out, but the IPs themselves were also burned out. And so as one IP said, what they and their team were struggling with was trying to solve the immediate fires, but they weren't really preventing fires. And of course, infection prevention is all about trying to prevent HAIs. But they felt like they weren't putting any mitigation strategies in place. They were just running from fire to fire. And then one IP said that they felt like not only have they felt burned out like at one point, but at several times during the pandemic. So the way that they described it, they'd kind of feel a little refreshed, then they start to get burned out, then they'd, start feeling a little bit better, and then they'd have another sense of burnout. And so it has been a long few years is basically the message that we were hearing. And of course, we're still dealing with the pandemic now. So what we did here, though, we did ask specifically, like, what's working? What can we do to help make infection preventionists more resilient, make them feel better mentally, physically? Like, how can we support infection preventionists? And we got wonderful recommendations from the infection preventionists in the focus groups about how to make that happen. So I summarized it all on this slide. So there were suggestions about allowing IPs to work from home periodically, insisting that they take time off, and truly getting away, unplugging, not being on call, not being required to respond in any kind of way. Involving EAP or counseling in some way, including having that available on COVID units so that staff can get real-time assistance when they need it, providing resilience training for staff, bringing in trained counseling professionals or training chaplains to help with that. There were suggestions about peer-to-peer support and assistance. Some talked about implementing daily huddles or weekly meetings to debrief and talk through challenges, because even just that process of talking can really be cathartic and help you work through some of that burnout. One IP talked about having a tranquility room or a space that has a massage chair, aromatherapy, snacks, or just a quiet space where staff could go for 10 or 15 minutes to just get away and try to do a quick kind of unwind before they go back to work. They suggested a forum where IPs can talk to each other about their experiences. One IP talked about reading books on resilience and coping strategies as a group. So they kind of set up like a book club almost related to resilience training. So they would assign, so to speak, a book about resilience. Everybody would read it, and then they would get together and discuss what was in that book and how they could implement that into their lives. Some talked about doubling the number of people on call to help spread out some of that workload. Many talked about financial incentives, paying for overtime if you were called in during off hours or had to be online, or just other kinds of financial incentives. Talked about stress first aid training, listening sessions with staff, and then making tangible changes. So not just letting people vent, but actually making changes based on what you were hearing, that feedback you were getting from staff. And then also sharing links for community webinars or other sources for wellness training so that staff could pursue that training in their own time and work towards their own well-being. So those are the findings from those two sets of focus groups. Now I'm going to briefly talk about how that data has been used to inform practice. So one thing that we found from the first set of focus groups that was a very important finding is that the workload was so heavy for infection preventionists that they weren't able to do some of that routine HAI prevention. It was leading to an increase in HAIs. And now, of course, we have great data about the very large impact of increased HAIs that have occurred due to the pandemic. But back then, what we were hearing was just that the IPs were so busy responding to COVID, running from fire to fire, that they weren't able to do some of their routine duties. But they weren't necessarily dropping those routine duties in any kind of strategic way. Because they were running from fire to fire, they didn't have time to really prioritize which work needed to be continued by them, which could be delegated to somebody else, and which could be dropped or set aside. So that left really inconsistent practice and potentially may have contributed to HAIs along the way. So that finding actually led the APIC COVID-19 task force to develop the IPC acuity scale, which hopefully all of you have heard about this. So that is the acuity scale that was developed to help IPs prioritize which duties they need to keep during times of not just the pandemic, but during any natural disaster, outbreak of an emerging infectious disease. Of course, now we're dealing with monkeypox, any other pandemic, whether it's COVID-19 or a flu pandemic that might come up. But during any of these times when the infection preventionist work is too heavy for them and they can't get to all their routine duties, then what do you do? How do you strategically think about your job and which duties you keep and which ones you delegate or which ones you might drop? This is intended to be used just on a short-term basis until that infection preventionist can get through that crisis. And it needs to be a multidisciplinary approach. So it wouldn't be the IP sitting alone in their office, like making these decisions about what they keep and what they drop. It needs to be a conversation that happens across that hospital or across that healthcare system about which duties could be delegated and or dropped. And I'm happy to send anyone a copy of the acuity scale if you're interested in seeing that. There's a lot of information. Obviously, I'm just giving a very, very brief summary of that acuity scale, but there's more information about it available on the APIC website. The other big, I guess I would say, outcome related to the focus groups and related to the surveys that the APIC COVID-19 task force conducted, and just the other information that's been gathered throughout the pandemic related to infection prevention, is the white paper that APIC developed about infection prevention and control as a field specific to COVID-19. So this is essentially kind of lessons learned and also recommendations about what needs to change for the remainder of this pandemic and to prepare us for the next crisis that we're going to have to address. Hopefully all of you have heard of the white paper. It's called Between a Rock and a Hard Place, Recommendations for Balancing Patient Safety and Pandemic Response. This is free from the APIC website. You're welcome to download this document and look at all of this in detail. I'm going to talk about it sort of big picture in the next couple of slides, but I highly recommend that you download this and read it. It's very, very dense. We actually started this white paper in May of 2021, so before the Delta variant had really been identified and hit the United States really hard. So we started on the white paper because we thought that the pandemic, thought it was ending or things were getting a lot better. We had the vaccine, there was all this hope, and it felt like the perfect time to talk about what have we learned, what can we do better for the next event, feeling as though this pandemic was probably on its way out. We made multiple revisions over the summer and through the fall as the pandemic continued to evolve. Of course, then after Delta, we had Omicron, we had, Delta just really changed the pandemic landscape. And the lessons that we learned were changing. Things were changing. We actually decided to finalize the white paper in February of 2022, realizing that yes, this pandemic is still going on, but we felt as though we couldn't keep sitting on all of this important information. Like we really needed to take action as a field to change some of these practices now to help us respond to the remainder of the pandemic and get ready for the next big event. So the white paper, as I said before, it's very, very dense. There are 10 different chapters, and each chapter has a great deal of information. All of this is evidence-based, so every chapter has findings, recommendations, and references to back up all of this information. So for instance, the chapters, including IPs as essential stakeholders, using hierarchy of controls to prevent transmission, surveillance and epi investigations, cleaning, disinfection, and sterilization, situational awareness, employee and occupational health, vaccination policy, intersections between healthcare facility, IPs, and public health, ensuring preparedness and long-term care, and managing communication. So again, great information about what we learned during the pandemic and what we should be doing moving forward. So this is a brief summary of some of the recommendations that APIC has made. And Many of you might have seen this. They have talked about this publicly on a national basis. They have met with congressional leaders to talk about these findings and these recommendations to try to change practice. So for instance, they recommend developing next generation universal personal protective equipment, normalizing the use of masks, addressing the supply chain failures that we've had, the need to include infection prevention experts in incident command and emergency response teams, putting properly trained personnel in long-term care, nursing homes, and other high-risk settings, building capacity related to infection prevention surge capacity, increasing testing and contact tracing, rapidly sharing data and making things interoperable around infection surveillance data, establishing strategies and actions to build vaccine confidence, fostering expansion of IPC as a field, and expanding infection prevention and control training to all workers. So in conclusion, this pandemic has had and continues to have huge impacts on IPC as a field. There have been advantages and disadvantages to this, mostly disadvantages, but there have been a few silver linings, more respect for us as a field, more recognition of the need for IPs, more expansion of the field, so that those are good things. We have learned a lot of super important lessons that we need to implement into practice moving forward. And it's important to know APIC is really listening to infection preventionists and responding to member needs. With that, I'm going to stop sharing my screen to take questions. And I also, I don't want to move too far off the topic of this, but I also did want to mention APIC has started a monkeypox response team in conjunction with the American Nurses Association, and they are planning on having a town hall or a webinar by the end of the month on monkeypox. So just wanted to let you all know that there will be information that will be sent out very soon from APIC headquarters. But to me, it's very important that APIC is listening to our members and trying to make changes to advance our field.
Gosh, Terri, thank you so much. So hi, first of all, hi, Terri.
Hey, Pam, how are you?
I'm the education chair for Atlanta, so I get to kind of facilitate the questions at the end. So who has questions for Terri? That was just a wonderful, wonderful review. Who's got some questions? I have one if nobody's got their. Mary, do you see any questions in the chat or no? Okay.
I am looking.
Okay. Let me do mine while you're looking. So that information was just so practical, and I think it's very helpful for everybody. So as you identified, you know, there's qualitative and quantitative data to collect, and we did such a good job of doing both, I thought. But, you know, now we're about a year out from the last focus groups, and potentially things have changed again. But I was wondering if there's any thought about doing like a long-term quantitative data, looking at APIC, the number of positions that people have, like, have we increased the number of positions in each of our facilities? Are there new ones? Has any people reorganized because of that, brought in different kinds of people? And I was wondering if we could actually even include that in the mega survey, you know, take some information from 5 years ago. How many people do you have in your team and trend it out? Have you guys looked at any of that?
We haven't. Many of you might be aware, so APIC recently started a research institute, and they hired a new director, Shanina, I can't remember her last name. So she's in charge of that research institute for APIC. And one of the goals is to, they're going to be developing their own research projects, looking at member data and collecting additional data. So I think it would be great. Hopefully that will be one of the priorities. What I've heard is that one of the early priorities will be to look at IP staffing and the impact of that on HAIs. I just don't know like the timeline for that. I know that like right now, Shanina is helping to lead the monkeypox response. So I'm sure she has multiple responsibilities, this being just one of them. But yeah, I think that would be fantastic. Right now, the APIC COVID-19 task force has not been meeting. It's been a number of months. So we could suggest that we collect collect data this fall. My guess is that right now the bigger priority for APIC is monkeypox. That is seem to be and it seems to be true just for people in general. My general sense is many people feel like the pandemic is not that it's over, but they're over talking about it and they're
Yeah.
over dealing with it. I think they're gonna be surprised this fall because I'm anticipating another big wave.
Yeah.
The new BA 2.75, I think, is really going to throw us another curveball, especially when it hits us at the same time as flu. But for right now, it feels like many people are just not interested in talking about the pandemic.
Yeah, I agree. I just thought I'd throw that out there because of the mega survey. It's already something that we're already doing. And I don't know, maybe they collected that data in the past because somebody just put in the chat, you know, I think a lot of programs are expanding, but there were a fair amount of layoffs of IPs over the first couple of years, you know, because the hospitals were so different and they were laying people off. So that's an interesting twist to all of that. Hey, Mary, were there any other questions in the chat?
Yeah, so we have another one. So what were the parameters for defining IPs in rural settings?
So we had members self-select. So when we sent out the recruitment emails, or when headquarters sent out the recruitment emails, it simply said like, these are the different sessions. And if you identify as belonging to one of these groups, like new IPs or experienced IPs, they would self-select. So we did not, we said like, you need to be in a rural setting, but we didn't give any more parameters than that. And people just self-identified as either being in a rural setting or not being in a rural setting.
Okay, thank you. We also have another one that came in, and I'm going to read it. It's a little bit longer, but I'm just going to read it as it said here. So I'm interested in what is heard about what policies and procedures are being followed, given that many emergency orders and standards were instituted during the pandemic, and some of those have been retracted, but are the hospitals changing their policies back or still based on ETS and other emergency standards that have expired?
That's a great question. So I can only personally give you anecdotal information that I have heard, like locally in St. Louis. So what I have heard is that our healthcare systems and hospitals are still following the OSHA ETS requirements for healthcare, even though like our mask requirements locally in St. Louis City and St. Louis County have been rescinded. So in the public, there's not mask use anywhere unless individuals just choose to be masked. But in healthcare, our healthcare facilities are all still following a mask mandate at this time. But I haven't really asked IPs in other settings, so I don't know. Like for your chapter or your members, feel free to throw it in the chat box if any of you have moved away from universal masking. That would be.
Northside Hospital, we have 5 hospitals and 500 clinics. We're all masking and still wearing eye protection. How about some of you guys? How about Mary? What about Piedmont?
Yeah, still same, universal masking. We actually are implementing more stringent guidelines for those who are not vaccinated too. So we're working through that right now.
How about Emory? Anybody on from Emory?
Yeah, we are still maintaining universal masking for patient care. And so that has not changed at this time.
How about eye protection, Jessica?
We are for all PUIs and COVID positive patients, or any sort of even monkeypox and those sort of PUIs, but for all patient care, the eye protection is starting to dissipate. It's becoming pretty relaxed and really hard to reinforce. And another piece of it for all visitors and care partners, we are ensuring that our team, those members are masking for all patient care as well, even if it's not a PUI or anything.
Anything else in the chat, Mary? This is really good.
Yeah, just kind of responding to that question. So NGHS is still universal masking. CHOA is too. So yeah, that's what we got so far. So it seems to be pretty consistent.
Hey, Kathy, this is Renee Watson, long time. I wondered how much data you have on generational differences in attitudes with COVID-19 and IPs. The one thing that you mentioned was, like a new IP coming in and saying, Rebmann, I didn't sign up for this. That's not different than what's also going on within healthcare in general, because you think about it, we're having to hire a lot of new grads. I don't know if that's the same everywhere, because folks just said, I'm moving on, and they just don't know what they signed up for, right? And so we are getting a lot of, our first year turnover rate is insane across all medical disciplines right now. And when, we think of HAIs increasing and things like that, you have to really look at the folks that we're hiring as new grads. They actually didn't get to do clinical. And so they were doing clinical on simulation dummies, not on humans. And so we've got to rethink the way that we educate those new folks, because instead of giving them a 3-month preceptorship, now they're like, okay, 2.5 weeks, and see, there you go, fly little bird fly. And so it's really a challenge. And so we've had to think within our IP department, how do we get back and basically get back to the basics with some of these nurses, and how do we fulfill training and at the same time, sustainability when you've got a 75%, attrition rate basically every 1.5 years. So you don't have any institutional longitudinal knowledge.
I haven't seen any quantitative data on that, just what we heard in the focus groups, what I've heard anecdotally, that this is definitely a challenge across multiple healthcare fields. There are physicians are also leaving at a very high rate. Nurses are retiring early or are leaving the field or moving into just non-clinical settings at an unprecedented rate, is what I'm hearing, again, anecdotally, but I haven't seen any hard data on that.
Cool.
It is definitely creating a challenge for healthcare.
Yeah. What do you think, Mary? It's 1 o'clock. Is there anybody else in the chat? That was great.
We have one other, if we want to just throw this out there, because some of their ones are just comments. It just says, how about managing respiratory protection program, given that OSHA released a mini respiratory program, but that expired with the ETS? So that was just another question.
And one last question, just thinking about any long-term qualitative study, just to add on your comment, Pam. I know that there is a lot of ask with having some sort of financial reimbursements for call, and just given that many infection preventionists are constantly on, so passing off the pager. The pandemic has hit our healthcare systems like crazy, and from a financial perspective, many budgets have been cut across the nation. And so when addressing that, I think, it's very important, but also just trying to find where is that fine line between, protecting our teams and healthcare leadership as well on how they're trying to prioritize many of these funds as well. And so just something to think of for any qualitative study, because that's always an ask, and it's something many of us would love to receive some sort of reimbursement or something. It's just part of our job description, is how it's always been laid out. And so not saying that that's always okay. It's just how do you speak to that and really try to maintain the resilience of your teams in that sense.
And just piggybacking onto that as well, is that all of the benchmarking IPs per bed size and stuff like that doesn't take into effect all of the ambulatory sites that also are managed by infection preventionists. And so how do we kind of normalize for that when you've got a footprint like many of us do in Atlanta of 100 miles, between your facilities, basically your outpatient facilities, and, what other primary care, radiology, and all of those things. So, I think we need to move past only benchmarking for IPs per occupied bed or per bed, but what it is maybe for adjusted patient day, which at least, brings in some artifact of ambulatory demand would be very helpful.
Thanks, Renee. Good
agree.
comment. Go ahead, Terry. Any final words?
Not about this, although I do have something weird and I hope this isn't unprofessional. My husband they have asked him to relocate to Jacksonville. So I am in the process of moving.
Oh,
If anyone knows of any connections or networking would be fantastic. I have been at SLU for 22 years. I have no idea how to find a job in another state. So if anyone knows of any contacts in Jacksonville and could connect me, I would greatly appreciate it.
oh my gosh. Well, congratulations, I guess.
Thanks. I'm
Oh, you're in a
excited.
melting pot in greater Atlanta, so I'm sure somebody has some sort of connection with Jacksonville.
Well, that's kind of what I'm hoping. And I figure everybody's like, you find a job through networking. I'm like, okay, I've kind of done that with all my St. Louis friends, but I need to expand my network.
Kathy, if you need a reference, you've got about 15, 20, 30 on the call right now who've worked with you since, well, I know I started working with you in 2000, I think, in public health. So I think you've got plenty of people you can call on.
Thank you.
Okay, Mary, you want to finish us up?
Yeah, sure. I think we definitely appreciated your presentation. That was really good conversation, and I hope everybody has a good rest of their day, and we will see you guys next month.
Okay. No, we won't. No meeting.
Oh,
next
just
month.
kidding. We have GIPN. I'm sorry. The following month. Thank you for that, Pure Check.
October. All right. See you guys in October. Bye.
Bye.